I will then introduce our second presenter. Thank you very much, Cliff, for a fascinating presentation, and it was good for me to revisit your research, which I thoroughly enjoyed being participating in when you were doing it. So now we are going to introduce Karen Wientjes, who's going to be talking about the role of mind and spirit in diabetic wound healing. Karen has a fascinating background. She earned her Ph.D. in mind-body medicine from Saybrook just this year, January of 25. She also holds a DPT, a doctoral degree in physical therapy. She has been practicing wound care since 1996 and has been a board certified wound specialist through the American Board of Wound Management since 1999. She founded her own practice, Brandywine Integrative Wound Care, in 2024. She is a professor in the doctorate in physical therapy program at Neumann University and enjoys teaching the next generation of physical therapists, emphasizing a mind-body approach. We look forward to your presentation, Karen.
Thank you. All right, I'm just going to share screen then. Okay, does that look okay for everyone?
Yes, looks
Okay.
great. Thank you.
All right. So I'm going to talk about the role of mind and spirit in diabetic wound healing, which was kind of what led me to Saybrook, is really understanding more than just the physical wounds that we have, but some of the mind and spirit implication in the wound healing process that I was seeing. And I'll just begin by saying, I promise you, I do not have any gory pictures of wounds, so you don't have to worry about that. We'll be talking more about healing in general, and a lot of it touches on self-care, like Cliff had just mentioned. Okay. Oops. There we go. Okay. I'll begin by just providing a brief background and purpose for my study, and then get into the method and the research questions and theory that guided my data collection and analyses. And then the main focus of the presentation today will be on my findings and what they revealed about the role of mind and spirit on wound self-care and healing. So just a bit of background to get started. I'm sure most of us are familiar with diabetes, and just want to emphasize here that it is very much a multi-system progressive disease that impacts the immune and the metabolic and the musculoskeletal integrity. The integument, though, especially that of the foot, is often compromised as well. And approximately 40%, approximately 1/3 of people with diabetes will develop a diabetic foot ulcer, or DFU, as I'll say, and 40% of them will experience recurrence in just a year. So that recurrence rate goes up to 65% at 2 years. And then complications, if we look at those, the complications such as infection associated with a diabetic foot ulcer occur in about 50%, with a 5-year mortality rate. And that statistic also rises to about 74% after amputation. So a big concern there. And with such numbers, I don't think it's surprising that there's an association between stress and diabetic foot ulcers. However, what I did find to be intriguing is that psychosocial stress can precede wound development, and that further compromises the metabolic function and in terms of healing and what we need there. According to the CDC, depression and anxiety are 2 to 3 times more likely among patients with diabetes. And this could very well be linked to the disease management that's associated with diabetes, the glucose and weight control and exercise and more frequent doctor appointments and things. But the development of a DFU, or diabetic foot ulcer, just adds to that complexity or the follow-up care that's needed. So there are additional psychosocial concerns associated with having a foot wound that may include things like reduced independence or even isolation, because they feel that this wound makes them not want to be out in public, body image changes, particularly if they've had an amputation, and a sense of powerlessness or lack of control over their condition. So what I'll be talking about today is wound self-care, and that's really defined as the measures or what a patient does when they're not in the clinic. So we see them, we take care of the wound in the clinic, it looks great, we send them on their way. What I wanted to really understand is what happens at home? How do they take care of this on their own? Because sometimes they come back and it looks quite differently. So the things that patients have to do at home might be cleansing that wound, redressing the wound, monitoring it to prevent or to make sure that they're not seeing any signs of infection. Oftentimes also wearing prescribed footwear, and then trying to get along with all their everyday activities that they need to do. So I did look at self-efficacy as well, and how that pertained to self-efficacy is that belief of their ability to achieve a goal. And in this case, the goal being wound closure or limb preservation. They don't want to lose any more of their foot or their leg. Self-efficacy is mediated by the perception of control over a condition and your confidence in your ability to do what's being asked, and the influence of internal or external loci of control. So those are some of the just main background that to kind of set up for this. And why is this important? A couple of reasons that this became significant, I felt, to look at. And the first being that the cost of diabetic foot ulcers is estimated to be between $9 and $13 billion annually. And that's a statistic from 2023. The financial burden associated with diabetic foot ulcers can result in or can come from emergency care, surgery, and then rehabilitation needs if an amputation does become necessary. I also still found global evidence exists that we're still seeing repercussions of COVID-19. So during that time, patients were not being seen as easily. They weren't getting in unless they were severe cases. They weren't heading to the hospitals and so forth. So that we see a severity in diabetic foot complications that began during that time. The other thing is that we're still seeing some limitations to healthcare and wound care supplies that are occurring since COVID. My scoping review of the literature also revealed that there is an abundance of literature on diabetes self-care and self-efficacy that focuses on prevention and other aspects of diabetes management. But I found few studies that looked at wound self-care once they had that diabetic foot ulcer. Like that portion of it seemed to be really missing. And even less of the studies that I found were occurring in the United States. So most of it was international. And then lastly, I felt this study was really significant because diabetes is a physical, mental, and psychological experience where understanding or better understanding their beliefs and things would help maybe describe what's going on with their self-management process and what they're doing. So wound care adds complexity to diabetes management. And my literature review really led me to conclude that the current instruments or the ways that we assess the psychosocial aspects of wound self-care are really lacking right now. So therefore, the purpose of my study was to explain how attitudes and beliefs about wound healing influence a patient's adherence and participation in the wound self-care practices, especially if they had diabetic foot ulcers. And that's really the group that I focused on. So for this study, I chose to do a qualitative case study design. And I followed the method of social scientist Robert Yin for my design, just to better understand what motivates patients to engage in wound self-care practices. So an explanatory case study design is suitable since I was desiring to really look at how and why a social phenomenon exists in a real world context. And it allowed me to gain perspective and this particular behavior through multiple viewpoints. Wound self-care served as my unit of analysis or my phenomenon that I was studying. And Yin also posits that we should have guiding propositions that really kind of set the stage for what we're going to do. So the guiding propositions that I had for this study was that patients who feel that wound healing is within their control will be more likely to participate in care. And then if patients describe a sense of powerless, they'd be less likely to participate. I also had alternative propositions that considered that if a patient felt healing was beyond their control, that may cause them to seek support and education. Or if a patient believed healing was just controlled by fate, that they would be less likely or not actively participate in their wound self-care. I don't know why that didn't advance, sorry. There we go. Okay, so these propositions helped me to form my research questions, with the first one being, how do patients with diabetic foot ulcers describe their role in wound self-care? How do they participate in their care at the clinic and at home? That's a big piece of what I wanted to understand. And then how do they describe their role in wound healing, the role and actions? And then my last question was, how does learning unfold for them and then influence their participation in the bigger picture of wound healing? So my search of the literature on self-efficacy and wound care led me to the following theories, and I ended up combining and using elements of each of these that I kind of have more in the pink coloring and here. So the first one is Bandura proposed the social cognitive theory to explain how people learn and make decisions. And that involves human agency, such as the environment, the people, the supports that they have. And then the other piece of it is capability, their physical skills to be able to do something. So I felt both of these were really critical components to their ability to manage their wound at home. They needed to have agency and capability, and that applied here. The other theory that I looked at was Antonovsky's sense of coherence theory, which I believed was relevant because it talks or speaks to that connection between stress and coping with disease. I'm talking about diabetes and the potential stressors for these individuals. So I incorporated this theory as it relates to their perception of meaning, the meaning of having this wound or what their role is, and also that sense of control in particular. So their control over their diabetic foot ulcer and the psychosocial influences that kind of form their attitudes and beliefs about healing. And then the last one that you see there was more recent. It's by Costa and colleagues, and they proposed a grounded theory model that specifically addressed the journey to management of a diabetic foot ulcer. So I became very excited that that existed. But what I found is that my research was situated really in the middle of this path or this journey that they described. So right here where it says realizing the seriousness of their condition and then beginning to learn more about self-management. That particular space for me seemed to be the cusp of that was where self-management begins, or taking that active role. So by blending these three theories, I aimed to extend the research of Costa, but then also explain more of the psychosocial processes involved with wound self-care. So my data collection, the way I approached this is I engaged a large outpatient wound care facility that was a research and healthcare facility in a southeastern state. The case itself, as I said, that phenomenon was bounded by that specific location and also by the time frame that I was there to collect my data. So it was over a 2-month period, and I visited 2 times and spent several days there. I developed a protocol for each of these data sources. That first one is the powerlessness assessment tool, and that is a 12-item questionnaire that assesses an individual's feelings of powerlessness. And it has 3 domains that I thought were very applicable. The instrument Domains are capacity to perform the behavior, self-perception of decision-making capacity, and their emotional response to perceived control. So I administered that to 20 patients that had diabetic foot ulcers for at least 2 months and were receiving care at this facility and doing some of their care at home. I also conducted 5 semi-structured interviews with patients that had diabetic foot ulcers, and each was a scripted protocol and conducted in a private room. And then to obtain more of a multidimensional perspective on this phenomenon, I conducted 2 focus groups. One was with healthcare providers, and I had 2 nurses, 2 physicians, and a podiatrist. And then in a separate group, I had caregivers of patients with diabetic foot ulcers. So I ended up having 2 spouses and 1 sister of a patient. And again, used scripted questions and explored their attitudes and beliefs in caring for patients with diabetic foot wounds. And then lastly, I did a document review of some of the items that they were using at this facility for patient education materials. So I collected about 12 different samples of handouts that they would give, videos that they would share with patients, as well as what their electronic medical record template was to record the care that was happening there. So following in, I was seeking a chain of evidence that would kind of come together as I looked at these multiple sources of data, looking for convergence. I had a code book that I would begin to keep track of any patterns or emergent findings from any one particular data source, and then see if I could find links to other ones to really, take in the multiple viewpoints. The first one here, the PAT, or the powerlessness assessment tool, I just did I used it for quantitative data. So it gave me more of the context of the group that I was seeing, and the responses helped to shape some of the questions that I asked in my semi-structured interviews that followed. The semi-structured interviews I conducted in person, but recorded it on Zoom so that I could take that transcript and review it and then give it back to the participant for member checking to verify the accuracy of it. And I did the same for the focus groups. Except for those, I used the flip chart, gathered information as the group met, and then verified back to the group that those were the key themes that were discussed in our meetings. I ended up also doing a cross-case analysis, or as I was doing my cross-case analysis and looking at the documentation, I ended up employing this Patient Education Material Assessment Tool, or PMAT. And the reason that I did that is because that social cognitive theory's elements of agency and capability really, I wanted to investigate a little bit more deeply. So even though these educational materials were passed out and shared with patients, this tool allows you to really analyze how understandable were they and how actionable might they be for the patient. So I did end up going back afterwards and applying that tool to the documents that I reviewed. So I followed Braun and Clark for their coding and analyzing the qualitative data, arranging it into, circling keywords, alphabetizing it, coming up with those themes, and then ultimately coming up with arrays, and then finally like a matrix that linked and allowed those main themes to emerge for me. So these are the main themes that I found with triangulation of all those data sources, and I'll go through each of them separately, but they did help me to identify the answers to some of my research questions that I had, and reveal a little bit more about how patients with diabetes and diabetic foot ulcers see their role and their actions in caring for their wounds when they are not in the clinic. So the first theme that I saw really involved the psychosocial challenges associated with diabetic foot ulcers. And the data that I had gotten from those preliminary surveys that I did, those PAT surveys, demonstrated an overall mild sense of powerlessness. So the total PAT score was 25.1 out of 60, so relatively mild across all three domains. However, when I looked specifically at this domain, the emotional response to perceived control, that was more in the moderate range. It was a little bit higher than the others. All of the interviewed patients and caregiver focus group members described this heavy emotional toll associated with diabetic foot ulcer care. And that elicited sub-themes, even within that just one area. The first that was universal was just this shock and rapid onset of complication. They almost all to a T described it really didn't look like much, and then all of a sudden it was a major change. So this patient number 4 here says, I had a little sore on my foot, and thinking no big deal. And then the next morning they took me for surgery, and when I came out, that's what my foot looked like. I lost half of it. So just this, not a big deal, and then all of a sudden, big change in their body image, in the severity of what was going on. Those are really prevalent themes. Loss of control also came up here as well. And several patients discussed how they felt that they were perceived as being less or as a handicap, and that there was a consensus among them of feeling a sudden dependence on family members, on healthcare providers, just that they really were kind of lost. So although the initial quantitative data showed a mild sense of powerlessness, my qualitative data really told a different story with that big emotional toll that was being experienced and that loss of control, which kind of leads to my second theme that emerged. So participants across all of the data sets cited consistent challenges with wound self-care, and they had to do with things like the lack of sensation that they had, or the inability for them to see or reach their foot or where their wound is. So some of them couldn't, just because of their physical ability, couldn't get to the bottom of their foot to see what was going on or to put a dressing there as instructed. The footwear was described oftentimes as cumbersome. They'd be in these bulky shoes to help alleviate pressure, and that was hard for them to navigate with. And then just regular activities of daily living, things we have to do at home, like take a shower or sleep in a bed. Now they've got this wound on or this protective brace on, and that becomes a lot harder just to do everyday things. So these challenges really impacted their sense of control over their condition, and then their attitude and belief about, am I going to be able to heal this, or am I going to lose more of my foot? So the second theme that emerged from this study involved how patients began to regain a sense of control after this initial real emotional shock to their system. And I found two forms or two ways that they started to regain control. The first being direct participation. So they found ways to adapt. So they realized, I need to take a role in this. I can get a mirror out, or I can use my phone and take a picture of the bottom of my foot, and then I now know what it looks like. So they really became creative in what they did to be able to start engaging in their wound self-care. So that skin inspection is a big piece of it. In terms of the cleansing and the redressing of the wound that would need to happen in those in-between times between seeing healthcare providers, some of them discussed setting aside like a specific place in the house where they would do their wound care, or they make up a little basket with all of their supplies so that it would be all gathered in one place. And that gave them a sense of, kind of like what Cliff mentioned, like, I can do this. Like, I have the tools I need, I have the space I need, and this is what I can do now. So I heard that come through in the interviews as well as the focus groups. And then offloading was definitely a challenge, but they adapted, they found ways. And one of the ways was maybe if they could, they purchased a shower chair. So they didn't have to stand in the shower, they could sit and they could prop their foot, or they could get around some of those loading situations or weight-bearing situations. Indirectly, these were some of the themes that came up. So all, except for one participant, all described strategies around glucose regulation as being probably the most common way that they felt they were helping this wound heal. Like that's how they were participating in the care of their wound, was by making sure they watched their sugar. Several noted that they did see a relationship between monitoring their blood glucose and how that wound did. And I put just a quote from one of the patients at the bottom here, and she actually had part of her foot amputated already, and this was now her second wound. So the second time around, she definitely changed what she was doing. She's watching her A1C, that monitor of what the blood sugar looks like over about a 3-month period, and found that it was drastically different the second time. It made a huge difference. Her wound is doing better the second time around. So that came through very much so, motivated them more so to take a more active role in their care. Other participants took steps to modify their lifestyle or their activity. They might have cut back on some travel that they did, or some work, types of work that they did, in order to do something that might help promote healing for them. Prayer also came up, and prayer, this was interesting for me to hear them say that this is a primary way that they regained control. So prayer and positive thinking were brought up, and this appeared to give them hopefulness and trust in something greater than themselves. It was reassuring to them that they could manage this, they would get through this. And they often spoke of, or used the term of, if I'm a good patient, if I keep believing and I'm following my instructions. So this theme, I felt, really directly addressed how patients with diabetic foot ulcers view their role in wound self-care and healing, like what their place and their contribution could be. And then the last theme, or the third theme that I had there, was this gradual transition that seemed to happen from the initial fear, shame, blaming, like somebody else should have been helping with this, to, okay, I understand my situation, and now I need to accept it and do something and have action. So that arc that occurred really was bolstered by education from the healthcare providers and from family, giving support and kind of encouraging. So patients seem to have to go through that transition of being initially just really shook to, okay, this is serious, I need to do something. Education was clearly happening through communication, through demonstration. As I mentioned, there were lots of handouts and patient education materials. Definitely, that was available to them. But on that cross-case analysis of the documentation materials, using that PMAT instrument, it looked at understandability and actionability. And there, when I looked across all of the materials, the understandability looked right on target. It ranged from 80% to 100%. So the terminology used, the information used was very understandable to, the type of population that would be reading these materials. But where it came up, I felt a little bit shorter, was looking at how it performed on actionability. So there we see like the handouts dropped to somewhere between 50 and 92%. So the materials that they're giving out and the actionability, how that carries over to actually doing it at home, dropped. The videos seemed much better. That scored higher. And I'll talk a little bit more about why that might have been in just a little bit. The support system piece of this, it really was critical to help patients move from that arc of fear to acceptance. And one physician in the focus group kind of made it like a sports analogy, that we need to kind of be team players here. Like nobody can do this on their own. And he was very encouraging, saying like, we need to get him or her involved, and as a team, we can do this. And I think that also helped to move that dial and get them from feeling really hopeless to more hopeful if they had this support team and they bought into the idea of active wound self-care. So this diagram really represented this whole transition that I saw with the population that I looked at. And if we look at kind of the 9 o'clock side here, we have the patient with the diabetic foot ulcer. The initial beliefs and attitudes really were like, this is a struggle to deal with this wound on top of everything else in my life and the diabetes that I'm dealing with here. So there was that initial loss of control and then a gradual regaining of control once they had this understanding of what their role is and how they could contribute to their own personal healing. From that point, with that understanding, I saw beliefs and attitudes shift to one of more determination and confidence in their skills. And that's really where we begin to see action come in. And that action is really bolstered by providers and caregivers offering that support so that the patient can ultimately start participating more in the wound care that's needed between office visits, and really making sure that they're being diligent about monitoring their skin and their integrity of their foot. So, you know, looking at the implications and ways that I can apply what I've learned from this, I went back to my research questions to kind of dig a little more deeply into some of the more surprising findings that I found with this study. And my first question was, how do patients with diabetic foot ulcers describe their role? And many factors seem to influence a patient's perceived capacity to heed the instructions of the healthcare providers. But lower confidence and a sense of powerlessness definitely supported that alternate proposition that patients with diabetic foot ulcers who feel that healing's outside of their control will seek help. And I heard that time and again from patients where they'd say, I've had other wounds before, you've always fixed me. Or like, I don't want to lose my leg, you need to fix this. So really that pushing off the responsibility to someone else. And that was consistent with some of Costa's work as well, that patients don't really take an active role until things become very serious, until it's like this or lose your foot. And that's when they start taking more participation into it. Patients sometimes can put limits on how much they're willing to participate as well. And I found that with several of the people that I had interviewed. So even if they had the agency, they understood why, and they might have even had the financial means to get their supplies and maybe purchase that shower chair, they didn't always choose to participate in their wound care. They, even if they had a recurrent ulcer or an amputation, they might have prioritized living life and deferring the care to a family member, or deferring it to the healthcare provider and just letting somebody else take care of it. So that was interesting. But the second theme of the patient's role in their wound or prioritization of wound self-care was dubbed the Southern perspective by the healthcare provider focus group. And that was really where I came to understand a little bit more about the region I was in and some of the comorbidities that are in that particular area of the country. So lower socioeconomic and educational status, predisposition to cardiovascular disease, more so than other states and even more so than within that state itself. So a further exploration of the demographics there revealed that health literacy and disparities in that region may be influencing primary prevention or healthcare understanding of their condition. So again, leads me back to that sense of coherence theory and thinking about stress. and all of the things that they may be dealing with at that time, and how that may influence how they make sense of, you know, what's going on with them and prioritizing their role in wound care. I think the big takeaway here for me was the implication being that we need to really consider socioeconomic factors and where the patient is in their spectrum of understanding and capability for action. Like, is this something that they can do? Because sometimes their goal is not to heal. Their goal is focused on something else. So we might be trying to heal this wound and prevent them losing more of their leg, but they've got bigger issues that they're dealing with, maybe other medical conditions or other things in their home life that the wound takes a very big backseat to. The second research question asked about how patients participate in their wound care. And one interesting finding here for me was that neuropathy played a significant role in how willing somebody was to participate in their self-care. I had one patient who went so far as to say that neuropathy was a gift and that it made it easier for the doctor to debride their foot and clean it up, and they didn't feel a thing. And it was kind of wonderful that you have this neuropathy. You don't have to, you know, it looks terrible, but you don't feel anything. But the con, and he acknowledged this, is that maybe if he could feel it, then he would be more inclined to do his care. So that perspective really kind of is eye-opening when you think about, if they can't feel it, then they don't know how bad it is until it's really, really bad. And that might be why we're seeing this delay in wound self-care or adherence to wound self-care recommendations. Caregiver support and encouragement does provide like those necessary reinforcements for patient morale and for participation, but disengagement also still occurs then. So sometimes the patient doesn't do much because they let everybody else do it for them. And that was something that came out in the focus groups as well as in the literature that I reviewed. So this idea of an over-reliance on caregivers may lead to more passive involvement by the patient and a reduced sense of their responsibility in it. So the takeaway here for me was really the need for balanced collaboration with the patient in order to maximize their healing benefits, or their healing outcomes, I should say. Research question 3 really sought to answer, how do patients with diabetic foot ulcers describe their role in actions? And that fits with the broader concept of wound healing in general. This line of inquiry probably had the richest data for me. Most of the patients and the family members talked about having trust and confidence in their providers. They trusted their ability of their body to just heal innately. And the message for glycemic control just was so loud and clear. So they are getting that message. So any of the functional nutrition folks out there, like, they definitely know that there's something important about monitoring their blood sugar. However, there was some confusion about how that actually links to wound healing. You know, I'm controlling my sugars, I'm not eating sweets, but it's still not healing. And when we look at the evidence there, there's research to suggest that even if we have really tight glycemic control, that doesn't mean that you're not going to have skin breakdown or develop a diabetic foot ulcer. There still needs to be that constant surveillance of the skin and monitoring of what's happening with the bony changes that occur, because they are at risk. So we can't just put everything alone on glycemic control in order to prevent wounds from occurring in this population. The other surprising finding was how much, I should say surprising to me, because I don't often, or hadn't often asked about their spirituality and how that impacts their perception of their role and actions in wound healing. And spirituality seemed to be coming up with every patient or family member that was involved in this study with me, and different for each. So I had one individual who expressed that healing was completely out of his control, that it was in the hands of God, nothing anybody told him to do. It was really just in God's hands. And then I had another family member that said, or another patient rather, that said they were so grateful, and they viewed God as working through the healthcare providers. So that was their gratitude for it, and they really believed that God brought them to this clinic and to these healthcare providers to help heal them. The healthcare provider focus group discussed another type of spirituality and belief that I hadn't heard or considered before. And that was that in that particular region, they said there's a Christian belief that if a patient verbally declares that they have a wound or they're not healing, that's an admission that they don't believe in God. So that God is not helping them. And if they have to come seek help, then that shows that they're not a believer, or their faith is in question. So such beliefs may explain why patients feel either more hopeful or more powerless when it comes to their potential to heal. I think the influence of God can be, or whatever that higher being could be, positive or negative, and it really becomes part of something that I now think is a dimension we need to really consider further and see if we can harness a bit more for optimal patient participation, because it seemed to be a very prevalent piece of this puzzle in terms of what patients do when they're not with us and how they perceive their healing. And then that last question that I had was about how the learning unfolded and informed participation. As I mentioned, ample educational support seemed to be provided, and it was very clear for the patients and the family members. But what was less clear is how actionable the directions were and the strategies were. And I think some of that goes back to the neuropathy and the lack of sensation again. And the educational materials didn't always address some of the household challenges that they may have. So perhaps our educational materials could be improved in that way. Regardless of the warnings and the preventative care and all the things that I think our healthcare providers, our health systems are doing to try to prevent or avoid amputation, that still seems to be the primary catalyst for patients to do something. They hear all this, but they don't do anything until it becomes that severe. So, the path to action doesn't seem to be linear. We have to kind of figure out another way into it. And I think the silent nature of that neuropathy is really a barrier for the patient as well as for us as the provider. Somehow we have to convince them that, the lack of sensation is not a good thing. Like, that's not making it easier. That's actually your major warning system for your body. And that buy-in and persistence is really what we need as a team in order to reinforce any of the education that's being provided. So, I think any good research study brings up more questions for you and other things you want to look into, and that certainly was the case here for me. So it piqued my interest in looking at some of the external loci beliefs on wound self-care. So I think perhaps an exploratory or phenomenological study might be interesting to look at wound self-care from, like, what are those spiritual beliefs, and what is this over-reliance or potential over-reliance on support systems? How does that affect or impact wound self-care? And then an offshoot of that area could really look at how we use gain-framed, like, empowering educational materials versus loss-framed consequence kind of things with our educational materials. Some might be more effective for certain individuals, like fear of losing your foot is more of that loss-framed, or something that might be empowering and along the lines of what you know, Cliff had mentioned as well, is just kind of bringing them back into their body and giving them that I can attitude, like I can do this, I can be a part of it in more of a game frame sense. So I think that that has an opportunity for us. Based on my work in this particular part of the country, I do think that a quantitative or even a mixed method study might be appropriate to look at health literacy and health and self-efficacy and see what that relationship might be. And then I think another complement could be looking at the capability and the competence to perform wound care. So, you know, oftentimes we get busy, we don't have time to check if the patient can really do what we're asking them to do. But that type of immediate feedback to patients and family members might help to reinforce their confidence that they can do this on their own at home. And it's like that final step. We don't just send them out with a handout, but we have them demonstrate back that they can do it. And you ensure that that's hopefully something that they can continue when they're not under our care. So just kind of in conclusion here, I think self-efficacy, or that perception of control and the belief that you can heal the wound, is influenced by physical factors such as that absence of sensation or just the ability to reach where the wound is and do the care that's needed there. Mentally, whether that person is feeling overwhelmed or determined to do everything they can. Emotionally, we might have that range of feeling like a burden to the family or to the healthcare provider, or just grateful for that support and knowing you have your team backing you. And then spiritually, as I mentioned earlier, faith in a higher power may influence the degree to which a patient takes a more active role or less active role in their wound self-care. For the participants in this study, amputation unfortunately appeared to be the primary catalyst for them to do something, to take that active role. And I would love to see us moving that before we get to that point, moving that target a little sooner. So I believe a multidimensional, a collaborative, a compassionate, a very person-focused mind, body, spirit approach is really needed with this population in order to optimize limb preservation. So I do want to thank Dr. Moss for inviting me to share my dissertation work here, and my amazing committee that I had, Dr. Wilmarth and Dr. Heinrich and Dr. Molinari. Really felt their support and guidance along the way. And I am ever so grateful to Saybrook because it has really helped me as a physical therapist. It's given me that complement to my physical skills of really helping me explore the mind, body, spirit connection that I think is appropriate for all types of healing, not just wound healing, but just healing the individual or working with individuals. So I'm very grateful for everything I've learned at Saybrook from my professors as well as my colleagues.